right, we're going to go ahead and get started. I think we're missing a few folks, but I know with the rain and who knows what's going on out there in the parking lot. I am going to go ahead and do roll call, and we've got possibly two folks. I can't see all the way at the end of the table who are joining us as new members that I will have introduce themselves. But I'm going to go ahead. Lexi is online. So Lexi, I'll go ahead and see who's here just because it's easier for me, obviously, being in the room. So Kelly Mitchell, I know is absent, so I will just say absent for her. Dr. Jim Wiltz.
Here.
Katie Stafford Cunningham.
Here.
Talee Clark.
Here.
Lexi Westerfield.
Here.
Laura Fife.
Here.
Kate Barrow.
Here.
I always forget. Do I pronounce that right? Kate Barrow. Okay, that helps me. Sorry, I've been pronouncing it wrong. Kim Dotson. Melissa Keys.
Here.
And then we have Nicole Hicks. Nicole, would you mind introducing yourself and who you're representing? Okay. Sorry. Yeah, and if you can just remember to speak into the microphone or you'll get a yell from me just because it is hard. If you do not, folks online cannot hear. So.
Sure. I'm Nicole Hicks. I'm representing InSource.
Great. Do you mind telling us just about yourself? I know I introduced just.
Sure. I have 4 children. I have one with special needs. He is going to be 30 in November. And we are navigating, the adult world with his layers that he is requiring, which is fun. So, and I've worked for InSource for going on 14 years. I am the supervisor of the North team. So I supervise the whole north side of the state. That's me.
Great. Thank you.
Thank you.
Appreciate it. Welcome. We're excited to have you. Let's see. Derek Nord.
I'm here.
Carrie Lee. Ann Titus. Kim Han, I know she had messaged me that she was unable to make it, but she'll be watching either online or watch the recording. And Jory Zolman, I don't think she's here, trying to look. She is our new family representative who is joining us. So she might be having some traffic issues, but she should be joining us, and I'll have her introduce herself after she gets here. Okay, I am going to tee up this video, and this is timely, and I know Erin is very excited that I'm sharing this with her in the room.
Jenny might be too.
So this is Erin Wright, is the director of the Bureau of Better Aging. And as you guys, over the course of, 8 months, I think, since maybe a year, has it been a year since aging, was the name change, as well as we were lucky to have them join the DDARS family. So I'm going to share the video that we, as you guys know, over the last couple meetings, we've been sharing the videos that we created about the bureaus that we're excited about and are great videos. And I'm going to share this, and then Erin is going to I know obviously most of you know what BBA is, but they've had some structural changes, nothing, crazy improvements, if you will, but just in the way that BBA is structured. So she's going to introduce some of that. So I'm going to share the video, and crossing fingers people online can hear and tech is working this morning. See, I just changed. Hold on. And then they leave the room and it's not going to work. Where's Scott? Hold on, let me see. Let me try something. And if not, Erin, I might just have you go and then we can share it after. I should have. Well, but I know, but it's not.
No.
I can't do. I know. Sorry, Erin. And then you're like, really? No, because then it doesn't. I can't do that because then I know what I need to do. Hold on. Talks amongst yourself. Hold on. I gotta hit. You have to go on here and hit share and share sound. It says share sound. Hold on. And I didn't click it. Does anyone remember where share sound is? There's like a button on Zoom that has share sound. Do you know what I'm talking about? Erin, just go ahead. Do you mind go ahead and starting and I'll mess with it? there's a button on here and I just never remember where it is, and you have to hit it every single time. So I'm going to wait. Go ahead. I don't want to hold people up and have everyone staring at you and me as we're trying to figure this out. So I'll go ahead and we'll work on the slides and we'll work on it as you're talking, just sharing about BBA.
Hi, I'm Erin Wright. I am the director of the Bureau of Better Aging. I have been with aging for about 8.5 years. Before I assumed this role, I oversaw our state and federal grant funded programs for home and community-based services, our functions as the state unit on aging, and also the aging and disability resource centers. So the Bureau of Better Aging really works to help individuals access resources, supports, and home and community-based services. We are designated, as I mentioned, as the state unit on aging under the Federal Older Americans Act. And with that comes the responsibility to designate local organizations to really serve as focal points and resources for older adults and caregivers in their communities. About 67% of our grant funds go to these local area agencies on aging. We also administer other programs such as adult protective services, some limited guardianship programs, residential care assessment programs. With our transition to being a standalone division to part of DDARS now, we really are trying to kind of determine our priorities while really staying true to our role as the state unit on aging. We have gone through a recent restructure prior to our merger with DDRS. We operated very much in programmatic silos, so we have tried to restructure ourselves to better support the programs and services that we administer. You can go to the next.
Okay, sorry, that's what I was trying to do. I was trying to read you.
By creating a centralized program and policy team with provider and vendor relations and quality and outcomes kind of wrapping around those core programs and services that we administer. We've been very fortunate to be able to grow our team in the last couple of months to increase our capacity to improve the programs and services that we deliver. So this is our new organizational structure. If you had seen it before, it was almost like a straight line. So we've really tried to move towards a very collaborative, integrated, but also functional structure. Next slide. With our transition, we are really focused on improving our internal policies and procedures. As I mentioned, just trying to settle into our new identity. We are really focused on trying to integrate with now DDARS. I will say I've been very welcomed and supported as we've become one of the tier 4 bureaus within DDARS. We are, with our new structure, really trying to champion our multi-sector plan for aging called Age Forward Together. This was a collaborative initiative that started and I guess was approved in the end of calendar year 2024. It is a 10-year forward-thinking plan that was really focused on aging within Indiana. It centers around age-friendly communities, reducing barriers to accessing services. There's a focus on civic engagement, employment, volunteerism, which really ties into some of the work that DDRS have been doing with Partsa Selm initiative around community integrated employment. So have that collaboration and tie in there. And then another component of the multi-sector plan for aging is around reframing aging and trying to combat ageism, not looking at aging as a disease or a disability, but just a process in life. As part of our responsibility as a state unit on aging, we complete a state plan on aging every 4 years that we submit to the Federal Health and Human Services Administration for Community Living. We are in the process of drafting our next state plan on aging. We currently are in the public comment period, so we are holding a series of listening sessions or stakeholder feedback sessions. The first one is today up in South Bend. We have one in Indianapolis next week, one in Evansville, and then we will be doing a virtual one next week as well. If anyone would like a copy of the state plan, email DA comments or let me know and I will send it. The public comment period ends on the 30th. We also have a dementia strategic plan, and we've really been trying to focus to ensure there's alignment between all of these different plans. An initiative that we are working on relates to legislation that was passed last year about conducting a study and preparing a report around realigning and consolidating the area agencies on aging map. Here's our current map. We currently have 16 different areas. These were introduced in the mid-1970s, and there has not been a change in the structure of the map since that time. So we are looking at the map to see if there may be areas that can be consolidated, realigned to better support administrative efficiencies, and also just recognizing that the landscape of aging and long-term services and supports has changed significantly in the last 50 years. So we're using this opportunity to just kind of take a step back and say, does this structure make sense? There are federal and state processes we have to follow if we are going to make any changes to the map. There first is the structure about the map itself. And then the next part of the process is designating local entities to serve as the area agencies on aging for those specific service areas. So in redesigning the map, it's not really, the focus is not on the agencies that are serving as the area agency, but it's really the structure of the service areas. Are there counties that would make more sense to be in an aligned service region? Does it make sense to focus more on a smaller urban area and change the boundaries of rural areas? There's a lot of demographic data that we're reviewing. We're having conversations with the area agencies about this. We had a day-long visioning session yesterday. Our goal is, oh, Jessica, go next.
Hold on, sorry.
Oh, it was just,
Yeah,
it's the timeline, which is probably more detailed than anyone wants to know, but we're really focused on coming up with the recommendations, and part of that is the funding formula that we'll use to distribute funds to each of the areas, which has to be approved by our federal funder. If there are any changes that come from this process, we wouldn't be looking at really implementing the changes with a new structure and new grants to local organizations until October of 28. Are there any questions?
It's too easy, Aaron.
Were you able to get the video to?
I was, and
Skip that part.
nope, Kathy's not gonna let that go.
Aaron, I have a
Um,
question. Sorry, Jessica.
Oh, yeah. Go ahead. Yeah, Lexi, go ahead.
So
I'll get rid of it.
What's going to be the BBA's relationship with Pathways then? Because I didn't hear you mention Pathways.
So currently we.
Hey, Aaron.
Sorry. Oh, I don't think I was talking to the mic at all. In the current state, we work with both Pathways and BEADS related to our role as supporting the Aging and Disability Resource Centers. The ADRCs have a role in waiting list management, so helping with that process, as well as really helping to navigate and support individuals when they have questions just around how does LTSS work in Indiana. We don't currently have any direct oversight or involvement in the delivery of Pathways waiver or even the Pathways managed care services. That's all OMPP.
Thank you.
Thanks, Lexi. Okay, I do have it working. So hold on one second. I got to go back. Cross your fingers. Someone chatted me to fix it. Let's see if it works. Oh, dang it. I did what she told me to do. Hold on.
It looks like it's muted in the top right hand.
I know. I don't know if. Let's see, it's weird because then it plays from my. Well, I did it. I wonder if it's changed because I did what she told me to do, and I
primarily but we also provide services and
okay. Fourth, fifth time's a charm.
BBA stands for Bureau of Better Aging. BBA primarily supports older adults and their caregivers, but we also provide services and supports for individuals with disabilities.
Livestream is one of 15 agencies in Indiana serving as an area agency on aging. And as an area agency on aging, we provide a variety of programs and resources to help older adults live their best lives.
BBA provides an array of services. We fund local agencies and support local communities to operate everything from senior centers to home delivered meal programs to in-home services such as help with bathing, dressing, cooking, those services that can help older adults remain independent and in the community.
Area agencies on aging such as Livestream provide a lot of different services for older Hoosiers. We provide everything from basic information and assistance. Where can I get energy assistance? Where can I get tax help? To more involved options counseling. What are my options for long-term services and supports? Care management, which is help coordinating those services and supports.
There is a whole network of local service providers that help individuals wherever they are on their journey through long-term services and support. So an individual can go to a senior center and get a nutritionally balanced meal and socialize, or an individual can have somebody come to their home and help them get ready for the day or take them to the doctor, those types of services.
One of the things that we do is we help people with all kinds of resources and information. For example, their medications they're on. How can they afford them? What are some programs that can help them better afford their medications? So we make sure that they are taking the medications their physicians have ordered for them so they can manage those chronic conditions better.
So what brings me joy in my work with the Bureau of Better Aging is knowing on a daily basis that I'm making a difference in my community and helping older adults to age in the manner of their choosing.
I feel like doing this work, I have seen the impact of systems and systems change and how we can make things better and how we can make the world better and Indiana better for older adults who want to age in their home and have services and programs available to help them do that. So I think it's a win-win. The person gets to stay where their friends and the people they know are, and it's supporting the local community.
Thank you. Think you did a good job, Erin.
Maybe we should watch it a second time.
Do you want to watch it one more time? Or do you want me to freeze it for the entire time when you're paid? Thank you. Yeah, it was.
So what's the age limit on the age living?
So the majority of our programs are for individuals 60 and over.
Okay.
We do have state-funded home and community-based services program called Choice that can serve individuals under 60 with
Okay.
disability.
Thank you.
Thank you. Okay. And if you guys have any questions, if you think of something, put it on your little parking lot sticker for Erin. She'll be here the whole time. Okay. I'm going to have Jory. Do you mind introducing yourself? You're like a grand entrance. No. Jory Zolman is our, we have the pleasure of having her as our newest family member representative. And so do you mind just introducing yourself a little bit about yourself as well? And you just, if you can use the microphone, please. Maybe a little closer. It's kind of, there you go.
Yeah.
Perfect.
I'm Jory. Sorry, I'm late. I parked at Idle Jor because I couldn't find out. It was so then I went to South instead of coming for north instead of here. So anyway, I made it. But I have a 47-year-old brother with significant disabilities. He lives in a group home in Northwest Indiana, Opportunity Enterprises, the Sheffield house. My parents live up there. They're 80 and 82. And so just kind of three boys, a 21-year-old and two 18-year-olds are getting ready to graduate, and a husband, he's an English teacher. I've been a special education teacher and social worker my whole life. So that.
Thank you. Yeah, no, great. Thank you. Not to put you on the spot, right? When you, okay, we're going to move right along here to Holly, who will be presenting most of the rest of the agenda. Follow along. We'll probably take a break. Just as you guys know, 3 hours, I need a break. Most of us probably do. So I will turn it over to Holly and try to follow her lead with her slides.
Oh, thank you. Jess. So
Are you guys hearing in the back okay? Okay, because I can't tell if it's working or not.
Yeah.
So.
I think it is. I think it is. Because Lexi could hear us
That's
earlier.
no,
So
it doesn't feel like it's very.
yeah.
Speakers and then
It's okay. Okay. I'll have them check it.
All right. Well, hello, everyone. Good to see everybody. Hope everybody made it through the rain. Yes, that's good because it was raining quite a bit on my drive in this morning. So I want to start with an update on case management. As we have discussed, we have waiver amendments at CMS right now to move to the selective contracting model for case management for the BEADS administered waivers. The slide here is slightly inaccurate. It says preliminary awards, but yesterday the final awards were notice was posted. So, but we had already sent these out. So just wanted to call that out. The final awards were to IPMG, Aging and In-Home Services, Unity, Inspire, and Columbus. Again, those are the entities that had the preliminary awards, and the final award notice went out yesterday.
Does that mean, sorry to interrupt, does that mean that like those are the case managements for everyone now, or is there others?
No, that's a great question. We're going to talk some through that. That means that as of August 1st, individuals, the only entities that can provide case management on the family support, CIH, health and wellness, and TBI waivers are one of these five.
I already have Inspire, so I'm good.
Okay. All right. Very good. But we'll talk through kind of that process, because I think that's important. So, so we are moving from slightly over 30 case management entities today to 5. So I wanted to just spend a few minutes, and that's meant to be demonstrated there with the graphic you see. So while we are seeing a decrease, or will see a decrease in the number of case management entities, we anticipate we will see an increase in the number of case managers. When we went to selective contracting before on the FS and CIH, what we saw largely were case managers continued in the field. I think you all have heard me say before, that was the funnest job I ever had. Kathy, don't listen. But case management was, yeah, fun job. But anyway, it also has, case management has a lot of individuals in that work that have a heart for what we do. So we anticipate a lot of the case managers, the bulk of them, will continue to provide case management services. We do expect, as I mentioned, an increase in the number of case managers as we move to the selective contracting because of the caseload parameters involved in the contract, which is 47, no more than 47 across all case, an average of 47 across all full-time case managers. So we know that we have some case managers currently supporting individuals on the health and wellness and traumatic brain injury waivers that have pretty significant caseloads above that. So that's why we believe we will see an increase in the number of case managers. So these 5 case management entities are actively recruiting. So if you follow any of them on Facebook, you will see that. So they are gearing up for the change. So as Talib pointed out, everyone currently supported on our waivers will need to choose one of these 5 entities if they have not already. And all 5 are going to provide case management statewide as well. If we can move to the next slide, please. So one of the things that we have already done is send a letter to everyone supported through those 4 home and community-based service waivers, making them aware of this change in model coming forward and the case management entities that will be providing case management as of August 1st. Those letters went to everyone, even if they had a case management entity that currently that is one of those 5, because we, again, wanted to ensure awareness. We have also been working with the existing case management entities and have provided them with toolkits that are on our website to support their conversations with individuals that they work with and their families about this transition and what this looks like and what decisions they may need to make depending on their situation and what their options are. That is tied to the case management monthly reimbursement for those current case management entities right now. So they have to do those things in order to be able to bill. And we have gotten some positive feedback about how that's going. We know that some case managers are texting families with all the things we've asked them to cover. Even if, for example, if someone has IPMG today, IPMG is still required to reach out to them and make sure they're aware of this, make sure they know that as of August 1st, these are the providing entities and you can stay with IPMG or I can offer you choice of another. So everyone, all the case managers are handling this in the same way. And we are seeing phone calls being made, text messages. And I was smiling at Carrie because she was a recipient of one of those text messages from one of her current case managers. And she shared that and it was spot on. The case manager did exactly what we needed them to do. So, so as of now, case managers are talking with individuals and making sure there's awareness, and families can start choosing now what case management organization they want to go with. I do want to note that the choice list for case management with those 5 entities working across all the 4 waivers will be updated for June 1st. So a family may say, I want provider A, and the choice list may not be updated yet if they're on the family support waiver for provider A. So that case manager will follow up with them to get them that choice list come June 1st, and then we'll move it we'll move that situation forward.
Hey, Holly.
Yes.
Lexi, do you want to ask your question now? Does it pertinent to this?
I'd like to ask you before we get too far.
Okay, go ahead. Go ahead.
So you went over the waivers that will be under these new, that will have these new not new, but like the updated 5 CMOs. My question is, when you look at the DDRS or the Arc of Indiana or any of those websites that list like the information about it, it talks about also pathways fee for service and money follows the person. Not to confuse anybody, but from what I understood, especially with pathways, is that they weren't like case management, CMOs weren't involved. It was like through the MCE. But from what I understand, fee for service means like traditional Medicaid, but I thought all pathways recipients were under an MCE. Sorry, that was a lot, but.
No, Lexi, no, that's a great question. And you are correct. Case management also does impact the money follows the person. It also does include a very small number of individuals in pathways fee for service. And it's a really, really small number, but those individuals on pathways fee for service operate much more similarly to the individuals on the health and wellness waiver today. As an example, they actually have a case manager that works with them because they're not managed care. So again, very small number of people meet very specific detailed situations that can allow them to opt into the managed care for pathways. But it's a very small number. But this does impact them as well. Great question.
Thank you.
Thank you. So we are also hosting meet and greets, both in person and virtual. We had our first one last night in Evansville. We had 26 different families show up to that, which I think was really good for the first one. We have a virtual one today. But those are scheduled and have been announced and are have been published, and we are getting people to attend. So that is great. And I want to shout out to our partners, our external partners, for sharing those as well and helping us get the word out to individuals and families. So. And those meet and greets, if you have never been to one, I will just give a real brief description. Each of the CMOs has a table there, and they are just there to answer questions and for individuals and families to have that opportunity to meet them and ask them, some of the questions that they would ask a case manager when they were interviewing a case manager, for example. So, and they have some of their swag there too. But yeah, it went very well last night, and we got some positive feedback from the families that attended. So
And the virtuals tonight?
There is a virtual today. There's several virtuals, but the first one is today. I believe it's at 2:00, but
just make sure we put those out through our listserv too. So hopefully everyone in this room is signed up for our listserv. But make sure if you're not, that's where a lot of this information, multiple ways is being shared, but
It's also.
I can put it in the chat. The DDRS to get updates. I don't even know if it's called a listserv. You can subscribe to it, and then you get emails with updates. Yeah, I can send you the link. You just need an email, basically, and it's multiple updates. It's not just about beads, but it's a good way. Yeah. And anyone can sign up. It doesn't have to. You don't have to be in the wait. It's just information. So
Thank you.
you're welcome.
And we are keeping updated information on the waiver reset page that has all this information about case management as well. So we do have to, because case management is a required service for HCBS, we do have to ensure there's a case manager from one of those 5 entities on board with every single person August 1. So if individuals and families have not made a choice by July 15th, we will auto assign them. They will retain the ability to make a choice after August 1st, right? If they want to go with someone else, that is absolutely fine. But we need to make sure that there's a case manager in place on August 1st. So if a choice hasn't been made by the 15th, after, our efforts, we're sending additional letters out in May. We'll be making phone calls to people who do not make a choice. Then we will auto assign. We are monitoring on a weekly basis the movement of individuals who need to make a change in case management by July 15th. We are monitoring that on a weekly basis. As you can imagine, right now, there hasn't been a lot of movement. There's been some individuals who have made a choice already to change, but we still, the bulk have not. We anticipate we'll see a spike June 1 because those conversations are being had now. I'm sorry?
Do any of the providers have caps? Like we can only take so many?
No.
Okay.
No. In fact, that is part of the contract. They have
Gotcha.
to be positioned to accept individuals. Yep. On a statewide basis. Yeah. Good question. Next slide, please. So the other thing that we are introducing in this contract for the case management is our value-based payment or value-based purchasing. What that essentially means is that we're going to be paying for certain outcomes with case management. This is just, I want to reiterate this, this is just the beginning. It's pretty basic, as you can tell. It's pretty compliance oriented at this point on timely completion of the PCISPs and the level of care, completion or timely completion on incident reporting and responding to CAPS for follow-up, mortality review, caseload size, and then trainings for case managers outside of state trainings included with that. So again, this is a start for the first contract year, but we will be growing that element in case management as we move forward. Yes.
So maybe this can go on the parking lot and be addressed at a future meeting. I would love to see what those value added services are and what your expectations are for those quality indicators, just as part of that advisory piece, so we have a good idea of what to look for.
Sure.
Especially when our constituents are calling us and asking questions.
Mm-hmm. Mm-hmm. No, that's great.
I have a question.
Yes.
So you guys know I'm Tilly Clark, but I have a disability, but I have struggled with case management issues for the past 7 years, I think. I don't know how long, but I have a new case manager. She's sweet. But what I struggle with is when a case manager takes my case and then it becomes too stressful or whatever, they drop me and then I have to have someone fill in. So that's frustrating. So does this mean like they need to, what would happen if they keep doing that?
Yeah, I think that's a good question. We can kind of talk about specifics. But, ultimately, when individuals or families receiving case management services have concerns, similar concerns, what we want them to do is reach out to us and we will work with them on an individual basis.
Sounds good.
To resolve.
I met my new case manager at my last quarterly meeting. I had to do the waiver reset stuff. So the questions were very personal and I kind of didn't like them because my mom used to do them, but I have to sit in that. And Darlene and I were playing with my Nido and it helped me calm down, but I was very emotional and frustrated because of the questions they had to ask. I didn't really like them because they were like personal, too personal. And I felt like, yes, I struggle with things on a daily basis, like depression and anxiety and mental health. But it's like, I don't think every time they need to ask that, because that makes me feel a certain way. And I feel like it sets me back, basically.
Thanks for sharing that. I think I know what you're referencing. So
Thanks.
it is good feedback. So with regard to the value-based purchasing or value-based payment, like I mentioned, these are, and to your point, Kate, these are very much compliance as we move forward with this model of case management across all our waivers. We will be looking at how to infuse more quality measures over and above just mere compliance, right? So did want to note that. All right, next slide.
Can I ask one more question?
Sure.
Just as a recommendation, when it comes to those value-based payments and those value-based services, how is the department or the division planning on communicating those to our community members who are receiving services? So there's a broad understanding of what value-based services means. Because I think that could mean a lot of things to different people.
It can. It boils down to the metrics that are being used to incentivize, right?
Yes.
So yes, and this is, again, sharing that we don't have, I mean, we have some of this data, but starting fresh August 1st, when we're talking about, when we're talking about a much larger pool of individuals with varying needs, the data may look a little different than it does today. So we will be sharing that information with this committee.
Just to piggyback on that, it is good. These, like you said, are compliance focused.
Yes.
And I get it. And I think I'm not suggesting that these don't have a direct impact on lives. I don't want that to come across.
Sure.
But it's a bit different. This is about pushing providers to meet area compliance. And I
Yes.
think that's a really good thing. It's a good opportunity though to test some internal processes. How do you communicate this out to individual people receiving services? Because if this is step one, where I would imagine some of these value-based will be much more about individual potential. I'm assuming individual outcomes. That's going to affect them much more acutely than training of case managers. And I realize that affects me, but it's just the responsibility, the impact is felt far more. So this might provide a good kind of a low entry way to how do we communicate this and get this message out, because come year 2 or later on, we move to a value base that's really about needing a service.
Right.
I'm already in the habit of understanding. So just a thought.
No, I appreciate that, Derek. And I think we are completely aligned on that, right? This is our first kind of foray into it. It's very basic. It's very compliance driven, but we will grow that, right? Like we have to grow our system to be able to really look at what quality measures are important, true quality, and how do we measure those? And then how do we incentivize providers, case managers, or whomever, right? To provide high quality services that results in the outcomes that people are needing.
Yeah.
Right. Yeah. I feel like this is something we'll be talking about more because we have identified as part of waiver reset that we really want to be more focused on the outcomes of services and supports for people. What's really meaningful? Are people getting something meaningful from our services? And what does that look like? And how do we, pat those providers on the back that are doing that, right? That are resulting in the outcomes. Yeah. Yep. Oh, yes.
Do you need to literally go like this? I mean, how close do you, how close? Okay. So Daryl, you guys literally have to be up on this. Because it's not, I don't know, people are I'm texting and messaging me that they're not hearing you guys. I don't know. They're telling me it's working. So, I mean, I would just get up into the microphone. They're hearing you, but I don't know. So, but yeah, I would just talk as direct as you can into it. I know it's kind of annoying, but just not as productive because I think it's multiple people are messaging me that they can't hear. So trying to fix it. So
You're
just
good,
be
Jessica.
very, love the microphone today. Okay.
Love it.
Hopefully no one's sick. I'm not sure. What'd she do? What'd she say? Did she make a joke? Yeah. Love that microphone. I mean, I have a loud voice, so I don't have that problem.
Yeah.
Okay.
All right. Let's go ahead and go to
Moving
the
on.
next slide, please. All right. Wanted to spend some time around level of care and our assessment tools, but want to start with just some level setting on level of care requirements for ICFID, right? This is not new. This is in federal code. We address it. We define developmental disability in Indiana code, but wanted to review it because, and again, stress, that has not changed. We have not changed the eligibility requirements. So that is an intellectual or developmental disability or related condition that manifests before the age of 22, that is likely to continue indefinitely, and then results in, and this is key here, substantial functional limitations in 3 of 6 major life areas. That's mobility, self-care, understanding and use of language, learning, self-direction, and capacity for independent living. So again, that has not changed, but wanted to include that here because I do think sometimes there is some confusion around if a person has a developmental disability, they meet level of care, and that's not accurate. There has to be.
It's not completely true because everyone has different levels.
That's true. That's true. Right. And it's really about functional need.
Right.
Yep. Good point. All right. Next slide. No, you're fine. You're fine. Just use the microphone. Okay.
I will.
Love it. Love it.
Love it.
Goodness. So I did want to provide an update, a bit of an update. So we have, of course, implemented new tools to assess individuals for ICF-ID level of care from the Entri suite of instruments, which is also used for assessing nursing facility level of care, different tools in that suite of instruments, but tools, all from the same suite, and all from Entri. Right now, we are using those tools. It's the Entri DD for adults, the Entri Chime DD for youth, 4 to 17, and then the Entri early years for 0 to 3 or through 3. Right now, we use those tools for eligibility reasons, right? But future state, they will be used in support of the design of the support level framework. So way back to waiver redesign, one of the things that we've heard very consistently from individuals and families is around the, multiple assessments, right? Every time they turned around, they felt like they were having yet another assessment. Maybe it was for eligibility, maybe it was for level of service, maybe it was for allocation, all kinds of different reasons. So one of our goals was to reduce the number of assessments that people have to, quite frankly, endure. We have to reassess level of care every year, but it's once a year. So these are the currently used for eligibility, will be used in design of the support level framework. We'll talk a little bit more about that today. I do want to note the ICF-ID level of care assessments, utilization of those 3 tools I mentioned must be done in person. That is how assessors have been trained. That is the expectation, that they are done in person, engaging with the individual. It is possible that the assessor who has been trained, there may be gaps if they're meeting with the individual and or things that they want or need to verify, and they may reach out to, you know, a direct support staff perhaps that knows the person, or a family member that knows the person. But that individual needs to be engaged. And I think that's what you were referencing a moment ago, is that you sat and answered a lot of questions, right?
Yeah, it was with my team too. So like I prefer to do it on my quarterly meeting, because then they get to understand everything that I do. But I didn't like it.
Yeah. So to your point, these are very comprehensive tools, and they are used. Every question is not related to eligibility, right?
Right.
But they are related to the individual's needs, and can support the team taking a more holistic approach about what does Holly really need, and how can we connect her, whether it's whether it's waiver services or something different like energy assistance, right? Or repair affair for some home repairs that need to occur. So they're very comprehensive. They really should be administered more as a conversation than just a whole list of questions. So we continue to work with assessors on best practice with those assessments. But to your point, individuals can choose to have other people present during the assessment, but it is not required. So sometimes those personal questions may feel a little easier to answer if it's just the assessor and
Definitely with like other people surrounded me, it made me feel better. But like my mom's my legal guardian, and so I prefer to have her there too. Sometimes it's just
that's what we all feel about our moms.
We butt heads, but it's like I love her, but that's just what it is.
Sure.
Kind of bouncing off what Tali was talking about. So I'm hearing you say if there's like gaps that a DSP or a family member might be reached out to. Excuse me, my throat got scratchy. I just wanna like make sure that when those conversations are being had with the family member of the DSP, that if the individual wants to be included, they should definitely be asked first if they want to be included, because they don't feel like things like that should be talked about without the individual, just in case the individual kind of disagrees with what the DSP or family members view is. We don't want inaccuracies from, because our lived experience, we know ourselves best, right? So yeah.
You are absolutely right, Lexi. Absolutely. And those assessors, whether that's a beads staff or a case manager, would always be expected to make sure that's okay with the individual, that they talk with someone else about them, right? Or that they're actually engaged in that conversation. Absolutely.
Mine was with my case manager. So
yes. Yeah. There's a reason we have continued with case managers doing those level of care assessments for ICF IID, and a lot of that is because those case managers know the individual, right? The expectation would be that if something doesn't kind of ring true in that assessment, that case manager would be like, oh, we need to delve into that a little bit more in this conversation to make sure we're getting accurately capturing things.
Can I just?
Sorry, go on.
Okay. And apparently I was the problem here with the microphone. Sorry, everyone. This tool is being used for eligibility. Its intention is also to be used, and maybe it already is, for the kind of level of care as well. So I'm looking at these somewhat separately, but I realize they overlap. Does that help? Correct me, because I'm looking at you right now. And
so apparently it's better. So you're
good job, loving the microphone.
Because I was turning it off. Sorry.
Good job.
Sorry, it says push. I pushed the button.
I did that one time too, and then I'm like, oh wait, you don't push.
This, it was really cute.
I was the problem.
So,
It's all Derek's fault.
and I'm going to try to answer that, but I may not. Let me know if I don't answer your question. When I talk about eligibility and level of care, I'm kind of lumping those together.
Okay.
Right?
That's good.
Level of care is the requirement that has to be met, or the threshold that has to be met to be eligible for home and community-based services.
So Elgo level. How about that?
Oh,
I'm sorry. So at this point, this isn't being folded into that, but the intention is to go that direction. So that's one thing I wanted just to get out there and make sure I was. So then I think my question is really about what we were just kind of talking about, and I think the concerns that was expressed about these are very private questions. And then the involvement of family members or just the individual themselves, they should have the right. People should have the right to just be them answering the questions. So I'm going to just share a concern that was brought to me yesterday by a family member, and it was really a question about, a person's their own guardian, and they didn't want any family there. That's their right, and I point that. But their concern were the answers correct, right? Or were they accurate? And I think some of the potential social, I think it's very common for anybody in being asked very private questions to be it in a doctor's office, and I'm sure some of these processes, to maybe not be truthful because of some of the social pressures related to that and talking to a stranger. So it's totally makes sense depending on how intimate those questions are. But so I just wonder how that affects the Elgo level if somebody's really not comfortable answering that question. So maybe they'll answer it in a more socially acceptable way. And what's the consequence of that? And is this something that we need to help people truly understand if there is a potential consequence with and the consequence being an Elgo level that maybe doesn't represent their need is really, maybe it's at a different level. So I don't know if we don't have to solve this. Maybe this is on a parking lot issue, but I think it's one of those big topics that's worth us kind of struggling with, because it's going to, as that becomes a greater gateway to the levels of support or the types of supports that you're able to access, we need to make sure that's as accurate as possible and that people are comfortable sharing their private information. That's uncomfortable at times. So anyway, that's all.
I think what I'll add, and just to step back a little bit, is that prior to the utilization of this suite of assessments, the level of care conversation was a very basic level of care conversation, merely to establish that minimum threshold for eligibility. We didn't get into a lot of these other conversations about what ultimately lends itself to the service planning piece. We're asking those questions now, and I think those are helpful for the team. I think it's also helpful for us as a system to Holly's earlier point, minimize the number of encounters that people have to have those kinds of conversations with us. But I do think it's an adjustment for people who have been used to that annual routine of the level of care conversation, and the service planning being an entirely different conversation that we have. They're completely in our system today, very separate processes. There's maybe some overlap, but it has to be, to a certain extent, previously very disjointed in the way in which those conversations unfolded. Now it does probably feel like now I'm unpacking everything all at once, and that is certainly, I think, an adjustment for people. But hopefully, as the system evolves in this waiver reset space and people see how that information is being utilized, both from the eligibility standpoint, but also, to Holly's point, in the service planning, we now don't have to come back to them and have another engagement around the service planning unless there's a change, unless it looks different than it did before, then yes. So I do think this is maybe a little bit of a culture shock or a shock to the system for people to be like, whew, there's a lot of questions here. And I do think that that's the new norm. I think for lack of a better term, as people adjust to the types of questions being asked, I think to your point, it's up to us to also educate people as to why there's value in engaging in that and being authentic and honest in what's working, what's not working for the person, so that we don't have to come back again or circle back on those areas where they felt I have to be socially acceptable in my response, or I have to answer this because I really like my team and I don't want to let them down. So I better, they've been helping me with this particular area. So I better tell people I can do this now, even though maybe I can't. Those types of things, I think, are things that we're just going to have to be supportive to our assessors in navigating and making sure that the information that we're gathering is valid, and that we have other ways to either triangulate some information or tell us that what we're hearing is accurate. But certainly, I think we're in a bit of a growing space right now as far as how people are adjusting to how that assessment just looks and feels different than what we've been used to.
Well, and I think the culture changes. Yes, absolutely. And I think that's a big change. But the connectivity of this exercise with the, not just eligibility, but the algo level is essential. And I think connecting it is, so this is such an important role. And I think it makes sense. And I think it's a really important direction, especially if the intention is to actually get services that people need when they need it, rather than saying, and this is what you get because we asked you these questions, and sorry, I don't know if you need it or don't. So I think that is spot on. And I think this is part of that evolution. And I think for all of us, I think the culture change, we need to help folks.
And I'm loving the microphone.
I'm loving the microphone.
I think also to keep in mind, particularly for the intellectual developmental disability side, what we've been doing is assessing for most people for that family support waiver, which service planning is not absent from that, but you get a certain amount of money and that's the allocation. And so the focus on gathering information to build out sort of the service array and supports that somebody would need, I don't think there's the right amount of attention being placed on it because of the way in which that waiver it's been set up to serve as many people as we possibly can with what money we have. And that's doesn't lend itself to good service planning discussion as part of that level of care, right? So I think that we'll get to a better space for those folks who maybe this feels very new, because we're getting definitely into more of the nuts and bolts of their lives than we were previously. Sorry.
I think, Talia, I was going to say one thing that struck me when you said it's not so much your experience of what you were asked, which I'm not, but maybe better preparing you, right? Like, I think that's what I heard too, is I think, and I'm not saying it wouldn't have made you uncomfortable. I don't mean to say that, but I think it sounds like you weren't prepared necessarily to know. So I think going in, maybe that's just something and I think you should have been. I'm not, but I think it should, because if you were, I think maybe you wouldn't have been. I'm not saying you wouldn't have been uncomfortable. I'm just saying maybe
this is my first assessment I ever sat in on. And that's the thing. Like, my mom would usually do it.
Still, if you were better prepared, you know what I mean? To have a conversation, hey, because I think then you would have maybe known more of, hey, I don't want this person here or not. So I think that's what I hear too, is I think it would have helped to make sure, we want to make sure people are supported and knowing what's going to happen. I guess
greatly supported. It's just, I didn't like the questions. It made me feel really uncomfortable.
Okay.
And
that's fair.
I just felt like they were prying into my daily life, which they need to know how I feel and stuff. But like, one question was like, how's your relationship with your family? I said it's poorly because, one, me and my mom don't always get along, and I struggle with that.
Yeah.
Like, she nitpicks, and then like I snap or get an attitude,
but I think maybe knowing
I go to 0 and 100, and I'm like, wait, I shouldn't have done that, but
Yeah.
I apologize.
Yeah. But maybe helping you understand why those are being asked. Cause I think,
Right.
because sometimes I think if we're just going in, and I'm not saying this is what happened, but if I just go in and I start with a list, like Holly said, it shouldn't be, hey, Talee, do you like your family? I'm not saying that's what happened, but I think to know why we're asking it, because I think if you don't, and I think if I was me too, and someone just started asking me questions, I'd be like, what the heck? Why? But I think to know why you're being asked, that it's not, here's why. And I think that's probably not always happening.
Yeah,
Is
I
that-
would like that because honestly, then I'd be okay like answering, but still it's gonna be a struggle for me to do.
I'm not saying
because
it's not going to be uncomfortable, but it might better give you a sense of why it's being asked.
Right,
It's
and
not-
then
It takes
and
away
then I
that
would
culture
understand it.
shock. Sorry.
yeah.
I think she had a question over there.
Thank you so much.
You're welcome.
We have to finish.
Sorry about
You know, I'm not ignoring you, right? I just need to finish.
I know.
Okay.
So, and
It's just to Jessica's point was all, I will be so brief if that's okay. And then you can move to wherever.
I'm going to go ahead. I'm sorry.
Yeah, go ahead.
So I think this points to a couple of things that we see at the council. One is that advanced preparation is really a support tool for people with IDD, but also as a sibling and a parent who's navigating this system. I've seen the communications that come, and they are very thorough, but also it's not necessarily plain language. And it's definitely not easy read. And so maybe one recommendation is to work with a group of self-advocates who can help put materials into plain language and easy read using images. I think that's going to help a lot of people better understand and prepare for what is in that tool. And also, I would, if it's possible, maybe a peer-to-peer training, or if people are more comfortable answering those types of very personal questions with a peer rather than if there's a poor relationship with the case manager or any other team members, then I can see how any way you deploy that tool is not going to be well received. So if there's a way to have a peer relationship that helps somebody prepare to answer those, regardless of the relationship with the case manager, that might be another tool, another approach to supporting people. I know you probably can't have a peer conduct or deploy that instrument with that person. It has to be the case manager. But I think letting individuals know what their rights are, if they want a friend with them when they're answering, I think that's a very reasonable thing to communicate to people.
And then they can also help communicate with seeing how they're doing too. Like maybe they are struggling. Like I struggle every day, but like it's hard to answer those questions personally when I just answered them like truthfully. Like you do have to answer them truthfully, because like if you don't, then it bites you in the ass at the end. But I mean, it's just whatever.
To your point, whoever spoke before Talee, and now I can't remember. Not to speak for the whole SAI board, but I think like the peer-to-peer or creating documents in plain language is something that somebody could approach self-advocates of Indiana on as a board, because that's something we do, and typically, and we're not to brag, but we're pretty good at it. So we're, not to speak for the whole board, SAI board, but I think typically we'd be willing to help with things like that to an extent. So.
Okay, go ahead.
Thanks. I agree. The preparation is really huge. Because some individuals are having assessments for different systems. Just an example, we're getting my son reevaluated at school, and I was sent an email from the school psychologist who I had never talked to, and she said, please complete this evaluation, whatever. And it was almost 200 questions that I was really emotional answering at the end because I was not prepared
Mhm.
to answer 200 questions about his deficits at that moment. And so I think the preparation is key. And I'm encouraged that case managers are being told to do these things conversationally, because I think that's different and having a conversation where it is tough to still answer those questions, but I'm not faced with 200 questions of the same thing over and over. So I think that preparation will be helpful. And again, and I think we've talked about this in other meetings for different things, like setting the expectation of knowing what they're walking into when they're doing it, because for that school evaluation, that wasn't it. And it's different. Our case manager has said, his evaluation will come up next month. We have a little preparation. I'm prepared because I'm here. But I think in general, that those extra steps really make a difference.
I agree with you because it's just hard to express myself to others, but because I'm a little shy or, going through something. But I will say this Sunday, I went to church and I loved it because I felt the presence of God and Jesus on a certain hymn, like a song. It's called It Is Well. And I felt sad and then joy. And it reminds me of doing self advocates to help other individuals express what they need. But when I express things, sometimes it doesn't go forward, and it's just frustrating.
So I'd like to add one thought to this, and it kind of goes along with what Dr. Nord said about having a fulsome conversation about this. They call me doctor. I figured nobody calls me anything but Jim.
Hello,
So I'm not-
doctor.
that was what that was. And I also didn't press the mute button.
Yeah.
So the stakes are really high when you get into, I get the level of care where you're establishing eligibility, but if we get into whatever, a new OASIS or a new algo or whatever the new iteration of figuring out how this translates into support needs and budgets and all that kind of thing. The stakes are very, very high. And one concern I have is the time frame of 3 days, which in the inter-I over and over and over again, has this occurred in the last 3 days? So, first of all, for a lot of things, like if you're kind of sad, if you have kind of depression, there's a good chance that probably has manifested itself in the last 3 days. But there are a lot of highly acute, very problematic behaviors that may occur once in a blue moon. I mean, some people, it's like around Christmas and all of a sudden they're hospitalized. That person has a little bit different support need than somebody who absolutely never, ever, ever is hospitalized, right?
Mhm.
And the one thing I would really encourage you to consider is how an appeal can work. And I'm not talking about every single person goes, oh, I lost a tiny bit of budget, and everybody's going to appeal to get more and more and more. But there are going to be some people who this upends their budget, or this upends something in their support, the supports they're provided. And I'm just very concerned about that 3 days aspect. Made positive statements. I mean, sometimes I go 3 days without that, There are other ones where you're talking about more explosive behavior and aggression and that kind of thing. Even the most aggressive person is not aggressive every week, and so you might have somebody who has physical aggression, property destruction, and sometimes it's big enough where some, law enforcement's involved. But that happened last week, so I give it a no. And that's going to really affect what your supports assessment is. And so I'm always
Right.
concerned when we kind of give up the human aspect to say, here, it's a checklist. And
Yeah.
I encourage you to give some thought to how that appeal process can work, especially in cases where everybody knows it's obvious this person shouldn't have, dropped half his budget because of the inter-I.
So no, I appreciate that and appreciate your comments, Jim. I think what I will go back to is these assessments are very comprehensive. And yeah, there is certain look back periods for certain items, but that's not every item. And it also asks things like how often and not just in the last 3 days. So without getting into too many details, I hear your concern and I appreciate it. I think, and I alluded to this before, there's a reason we have case managers doing these, right? Because they know the individual. They also, and if in the event that they don't, let's say it's a newer case manager, right? They have that individual's file as well, right? All their information about their progress towards, in various services and all of that information. So that when they're doing that assessment, if something doesn't quite ring true, they can dig in a little deeper in that conversation and find out. We expect that people would grow in their skills as a result of our services, right? That growth will look different depending on the person in the area, but we want to make space for people to actually gain skills and to recognize that, as well as when individuals maybe, I'll choose this because it's me. As they age, sometimes we lose some skills, right? Or our strength areas change. So these tools are sensitive enough that I think it will, or we believe it will pick up on all those things. I also want to mention, because of all the great conversation around kind of setting the stage and those conversations to help prepare individuals for these assessments, because they are very different than what we have been doing for a number of years. We have a learning collaborative for those assessors, the mentor assessors, and all of this information we can take back to that learning collaborative and talk through what are maybe some individuals are doing that preparation a certain way. How can we share that information and that best practice to better position individuals and families to be ready for these assessments? So your comments around preparation and setting that stage is very much appreciated, and we will share that.
Thank you.
I suspect this is maybe your last bullet, so I'll just preempt it. I'm asking these questions mostly because I think there's a broader community with these questions. I was in a conversation with a family member yesterday, and kind of 3 things that came up. So I figured this is a great time because I can say it, but I think it's more important that they hear. And Holly, I think you and I we chatted about this last week. There's a perception or there's conversation out there that people have lost their waiver because of these assessments. That's the first. The second is the denial pending language in the review process for those that language, and what does that mean? And then the third is appeal process. Those weren't even phrased as questions, but I'm just going to throw those really volatile words out and let you manage what comes next.
Well, thank you for preempting it, because that's the perfect segue, Derek. So yes, so we have been doing these assessments now since February. Very few finalized denials have been issued, and there is a reason for that. These are new tools, as we all know. These are, in many cases, not all, because we have been using the Inter-I suite of instruments on the nursing facility level of care side. But for some case managers, particularly in the space of individuals with intellectual and developmental disabilities, these may be completely new tools to them, right? So as a result of that, we've got new tools, new assessors. We are taking a lot of care in reviewing any assessment that is flagged for us to review, because that is, case managers can do that. But also any assessment that appears to be borderline on eligibility, right? And when I say we're reviewing it, we're not just looking at it and going, oh, okay, right, and clicking a button. We're looking at it for that individual, and is that assessment consistent with what we see in the individual's records, right? As a way to validate on an individual level that, okay,
this assessment looks to be accurate based on the information we have and the actual assessment. So we are taking all that very seriously, obviously, because and we've talked about this, but we know we need to get the right services to the right people. We also know that there are individuals in services who are not going to continue to meet level of care. And that's hard. That's hard for them. It's hard for the case manager to deliver that. It's hard for BEAD staff, right? It's a space we haven't been in a really, really, really long time, approving 99% of people that come in the door. So we are working with case managers about what that looks like, how those conversations can be had and should be had, and how we're connecting people to other resources. But we are taking great care in any of those, reviewing any of those assessments that appear to be result in denial, as we should. The appeals process, glad you brought that up. Thank you. That, as with anything, any adverse action, individuals will get written notice of the decision with their appeal rights. So the due process is in place and will remain in place through this entire process. Individuals that are determined not to meet level of care, whether that's people walking in our doors at the district office, so to speak. Part of what we do today is connecting them with other things, right? Because very few individuals walk into BEAD's office, apply for services, and immediately get services, right? That doesn't happen. So we've been referring folks for other and connecting them with other resources for some time in those situations. For individuals in services, there will be a transition period if they lose eligibility or level of care. And during that time, the case manager will work with the individual and the team on a transition plan, what that looks like, and what other resources that person needs to be connected to. As an example, if we're talking about maybe a 40-year-old individual who's been in services, is working a job, let's just say the person's on the CIH, gets residential HABs and behavior supports, and extended services. What's that look like? What's that transition plan for that individual? It depends on the person, certainly, but it might be a referral to the Center for Independent Living. If they need some just connections, right? Or maybe some centers for independent living, they all do things a little different, right? They're all a little different in what they offer. It might be rep payee, or that might be a local bank, right? Depending on the community and the person. It may be a referral or a discussion around state plan services. It might be a connection with some sort of support group or a CMHC perhaps, or whatever might support that person. But we're not here to say you're no longer eligible and next week we're terminating your services, right? Services will remain in place through the appeal process if people appeal. But I will say this, and this will date me too, like 30 years or whatever, or 20 something years. If a person is determined not to meet level of care and launches an appeal, that team, that case manager, needs still to be having those very real conversations about, if this appeal results in a denial of level of care, we need to be ready. We need to be planning for that, and we need to position them to be ready for that, if that makes sense. I want to just circle back really quickly to this conversation around level of care with the NRI suite of tools. Obviously, I think, and maybe this bears reminding, I think our system is working to or toward a place where we can hopefully have one encounter and identify the right waiver for the right person at the right time with the array of tools that we are operationalizing, and also be in a position to have that service planning happen essentially simultaneously. And I know there are some concerns around how some of the questions are framed and time look back periods, and we have seen some communications around people being advised to go into that assessment and share their worst day, and that be the lens through which they answer those assessment questions. Share your worst day in the last 30 days, in the last 60 days, whatever that may be. It needs to be your worst day. And I would just say, we can't do that. And I would really put forth to this council that if we are doing service planning based on someone's worst day, and we do that for 50,000 people, we are going to be in a very tough spot. Service planning conversations can happen at any point in time, even after their service plan budget has been issued. If something changes, that service plan should change to reflect that. So it just encouraged folks to be thinking about, we do not want to move forward with a deficit-based mindset about the people that we are supporting. We do want to move forward with a dynamic system that can adjust to be respondent to that person's changing needs over time.
Thanks, Kathy. Yeah, Tom.
Just a question on the back to the appeal question. If someone is appealing their denial of eligibility, if the NRI suite of tools is utilized for that determination, do they get any information about their assessment from NRI for the purpose of their appeal?
Oh, sure. The actual assessment, like their responses and stuff.
So
Sure.
okay, so they'll receive that for the appeal process.
If
They'll
they
receive the reason.
Yes, they'll receive the reason. Ask me your question again, Tom, because I don't think it's just what?
There's lawyers arguing. So the actual assessment is being utilized to make a determination for eligibility. So that's what is being relied upon. So if someone's going to appeal that denial of eligibility, what information from that assessment are they going to have access to argue their appeal?
They will have their determination letter, and they can have a copy of their assessment.
Okay.
Yeah.
Okay. Thank you.
Mm-hmm.
Do you want to clarify?
Go counsel. I do have one question. This is Kate. On the example you gave with somebody who is on the CIH waiver and they're getting lots of residential support, but they're successfully employed and have living their good life, their vision of a good life. Is there a mechanism for you all to determine whether or not those supports are what is leading to that person's success? Like maybe they are employed because they have the level of care support that are receiving. Do you understand what I'm trying to ask? And I just worry about going from a CIH waiver level of care down to community referrals. If there's a possibility that a family support waiver structure with still some of those things in place could continue to support that person to live independently with the right level of support, rather than just going down to all community-based services.
So,
and that's just based on your example.
Yes, no, that's a good question. I do want to clarify that if someone doesn't meet level of care, they would not have access to CIH or family support, because it's the same eligibility for those two waivers in terms of the level of care. So we would, again, work with what are the person's needs today, right? And how can we connect them with other resources outside of HCBS to address those needs?
And I think I wanted to clarify something you said, because you talked about CIH level people And the folks on that waiver are a heavy mix. There are some people who have some truly exceptional needs on that waiver, and there are individuals who have transitioned out of a group home to the CIH waiver, or they've met some other priority criteria at some point in time. So their budget may not reflect, and their service need may actually not reflect an emergent need at the time that they are assessed. So that's I think just an important clarification for people. I think what you mean is those folks who are currently getting a higher level of support from our system and then are determined at some point to no longer meet our level of care. And I do think that's where we need, truly suggestions, input from this group on how best to maybe walk somebody through that transition to kind of offboard them off of that waiver. Because to your point, we wouldn't be able to offer them a lesser amount of services or an alternate waiver because they wouldn't meet that criteria either. So it's really thinking about forcing the system to have conversations all along someone's journey in the system about transitioning down or stepping down from services and supports when they don't need them. Obviously, we don't want to create a cliff for anyone, but I certainly also don't, and I think I've said this at other meetings, I don't want people to wait until that level of care to figure out that that we kind of already know maybe that somebody's not going to meet that eligibility criteria before we start talking about this isn't going to work and we can't continue to offer this level of service. I can't think of an example of somebody who would have those higher need waiver supports who it may be impacted by that, to be honest, but that doesn't mean that there isn't any. So
I just want to add, I think it comes down to the case managers because they're the ones in the homes and seeing it, and for the case managers to have the best training in communication because they're the ones that are going to be seeing it coming more than a piece of paper.
Yeah, good point. Okay, Lexi, I'm gonna go to you, and then we need to keep moving. So, and then after your question, we'll take a break.
Okay, awesome. Thank you.
You're welcome.
I think I want to go back a minute. It's been a minute since it's been mentioned, but we talked about, Holly talked about, the good thing is like the case managers that are the assessors, they know most likely, probably more often than not, they know the individual being assessed, or they know their file. But I think kind of the elephant in the room, something a lot of people are concerned about, is will there, when waiver reset happens, be a transition to Maximus? Because Maximus assesses individuals and knows pretty much nothing about it. And we're seeing an issue with that a lot on health and wellness, TBI, stuff like that. So I think a lot of people receiving ICF IDD services are very concerned that Maximus is also going to be doing those ICC or ICF IDD level of care assessments.
Yeah, that's a good question, Lexi, but currently there are no plans to move those eligibility or level of care assessments for ICF IDD.
That's good news because I'm one of the people that was concerned about it, and I think a lot of people were. So,
all right.
Thank you.
Thanks, Lexi. Okay, we are going to take this is exactly on time. It's crazy. Okay. 10:05, we're going to take a 10-minute break. So we will be back at 10:15. That's okay. 11:15. Okay. We're going to
question.
Hold on one second, Tilly, just because it's loud. Got to get people. Okay, go ahead.
Sorry.
Just start talking.
So I have a question. So hey
guys, we're going to go ahead and get started just so we can get through it. I'm not holding you guys. Okay, go ahead, Tilly.
So I have a question. So say,
is this related? Sorry, I just want to make sure. Is it same? Okay, I just want to make sure in case it was okay.
But
No, you're fine. Go ahead.
know how people get money for assistance for their bills?
They get what? I'm sorry.
money assistance for their bills.
Yeah.
Let's just say, well, for me, I was trying to get for the energy assistance and I got denied. But what's frustrating on that is I have a lot of bills, but I don't know how to put it. Can you help me?
Oh, I think just she was mentioning
Oh.
that it can be for people that we're referring to that as a support. It is
Oh.
not consistent in who gets approved for that kind of
Oh.
support. So just more of a, I think, FYI for
Okay.
people.
Okay. Thanks.
Thank you.
Okay. Thanks. Okay. We're going to move on here. Let me get here. Okay. So we're going to move on to waiver amendments. Moving on with Holly.
Me again. All right. All right. Good thing I got a strong voice here. So just a reminder that we do have waiver amendments for all of the beads administered waivers, as well as, and that's not on here, but the pathways for aging waivers are at CMS with a planned effective date of August 1st. That includes, of course, the case management that we've been talking about, as well as some other components that we've discussed in previous meetings. But those are at CMS under review, and we anticipate having those back in July. I can't give a date because I'm not sure when that will be, but we expect them to come in July. So just wanted to provide that update. And then wanted to talk some more about waiver reset, just to ensure that we are providing information to you all so that you all can kind of track what's happening with regard to waiver reset, and that we continue to focus on the goals and understanding the why behind the reset. So, and you've seen this slide before, you're probably going to be tired of it, so I'll apologize in advance. But the goals of the waiver reset have been steady throughout this process. And one is simplifying the system. It's not news to anyone that the system can be difficult to navigate and confusing for individuals and families. So we know that as part of waiver reset, we want to make our system more understandable. We already talked about reducing the number of assessments that individuals have to go through, and then also updating the services that are offered. Again, based on feedback we've received from those that we support, and those individuals that we will likely one day support, we know that our services need to be updated, and we need to re-examine kind of what we offer and how those services are delivered in some situations. We also know we need to improve support coordination. I think we've heard a lot about that this morning when we were talking about the assessments and those conversations that are taking place or should be taking place. We know that in the coordination of services and supports, that those case managers need to know what's out there and available, and they need to be able to connect individuals with other services, paid and unpaid, and actually help them maximize all of those resources they may have available to them. That's not new. We've been talking about that for years, and that is unrelated to an individual's eligibility status, right? It really, all of our services should be focused on connecting people so that they're more included in their communities, whatever that looks like for them. Enhancing quality outcomes. How can we, as part of waiver reset, offer quality services and then support providers in ways that they can provide those services. And I think the quality piece is part of that value-based purchasing or paying for outcomes, whatever terminology we want to use. It really is, how do we support those providers of services to aggressively work with individuals and families to help them reach the outcomes they need from our services.
Holly,
Yes.
I know that the whole idea of paying for quality and the value-based payments and all that, that's something that we're all getting kind of used to that terminology and feeling like that's a direction that we're heading in, right? Can you give any salient examples from other states that you've learned, or just that DDARS is thinking of, in what direction are we going with this? I mean, if you look at the value-based payments that were in that one slide for case management, I think we already discussed that being primarily compliance. What might be a good quality metric that you would pay for, or what are you guys thinking?
Well, I think, that's a great question, Jim. And I don't have any other states in my back pocket that I would speak to, just because I don't think I could necessarily adequately represent another state without, making sure and reviewing it recently. But we have, and we'll continue to look at what's happening in other states around this value-based purchasing, so that can inform any decisions we make. I think one of the things that is important from my perspective when we're thinking about paying for outcomes is, not just saying, okay, we're going to pay for this, but we really do have to build to it. And I think Derek kind of alluded to this. We kind of start with gathering that data, looking at those compliance matters, getting that nailed down and in place, and then build from there. But I think the outcomes would differ depending on the service, right? I mean, we have music therapy, rec therapy that are therapeutic services. And then we have things like today, and we're talking waiver reset, so things will look differently. But then we're thinking about like participant assistance and care pack in attendant care. Those outcomes would look very different, right? And so I think it would depend on the service, but certainly we can take that back and perhaps carve out some time in a future meeting about how we might consider value-based payment for some of the services. So I think that's a great question and a great suggestion.
And I appreciate your answer, because that's basically, I think that's sort of the stepping stones that you need to get to where we are.
Sure.
I got to say that when in your comment about like rec therapy and music therapy, those are therapeutic services, and they're going to look different than PAC. I mean, I can see from a compliance standpoint where there are some similarities, but like on quality, I guess maybe I'm just like lacking imagination, because it's really hard for me to come up with specifics that I'm thinking, oh, okay, here's something that would be a quality metric that the state would pay for in lieu of unit-based system and the quantity. Simply saying we're going to move away from units and we're going to move away from quantity and we're going to move to quality, I don't think anybody would disagree with that as a goal. The devil's in the details, though, and it seems difficult if you're designing a new system and then the payment structure is based on this thing that we are even having a hard time discussing or putting our finger on. That gives me a little bit of trepidation going into the future of like, well, what is this going to look like? So I think I'll try to hone my imagination skills in the future to be able to come up with something, because it's really difficult to really, everybody knows quality when you see it. How do you measure it, and how do you put that forward into something that then becomes a billable service?
Yep. No, I think I agree with you, and we are always open to feedback. If you do come up with suggestions for value-based payment or paying for outcomes, but
I'll just speak to, I think we've talked ad nauseum with this group about employment. I think we've emphasized at the advisory council quite a bit outcomes around employment. That will be an area of focus, more than likely. The degree to which the services being provided are leading toward someone's employment outcomes will be looked at and evaluated as far as how can we incentivize services that get someone successfully toward an employment outcome or the outcome that they are working toward. And that could be something that's not employment, but in that same kind of realm. I think that one's coming to mind again because we've talked about it so heavily with this group, but also because the origin of us talking about it at this group have been self-advocates saying we want competitive integrated employment. And so I think, at least from my perspective, and this is where you all, are welcome to bring forth successful ideas or innovative ideas from other states who have implemented a value-based payment model around employment supports or employment outcomes that either for a particular service or for a team to share in a value-based payment because they were collectively able to work together to get somebody that outcome. That's just a very high level example. And to your point, Jim, the devil's always in the details about how you execute that. But that's probably where the most attention or emphasis has been internally for our team because of just some of the work that has been occurring with the innovation pilot projects and some of the other APRA related initiatives that we undertook a couple years ago.
Yeah, I was gonna say that, Kathy. I think that, and Melissa has a lot of experience in this too. I think with employment, but right, if there is an employment goal, and again, it can't just be does the person want a job or not. You had the conversation, you get paid, right? That's not going to fly, right? So if you've discussed employment and it's an obstacle, what are you doing to either address that obstacle, right? And so I think that for employment, it's not just is there an employment goal? You get money, right? You've reached the outcome, because that's not what's going to happen. Someone's going to write an employment goal so they can get that extra $20. A lot of times, unfortunately, that's what's going to happen, right? So how do we build it so that it's actually there's things in place that's incentivizing more than just maybe checking the boxes sometimes. So but employment's, like Kathy, I was going to say, is what's coming to mind, because I think I don't know all the research on value-based, but I think that's probably Melissa could jump in, probably the most used right now, or at least being explored, at least nationally, I would think. Do you think that's accurate? Maybe not. I don't know. Am I putting you on the spot? I don't know.
No, that's fine. I don't know.
Yeah, you're okay. Just don't hit the button like Derek.
Don't
Don't mess up everything like Derek did.
All right.
Yeah. So, when you think about values-based outcomes, there's almost two different types of outcomes-based things. There's services that are meant to teach a skill and services that are meant to help a person achieve an independence goal or an ability to increase their proficiency at doing something. And so the outcome for that might be the attainment or progression towards that goal. But then there's other services that are more filling a need that the person may not be able to meet themselves. Transportation, feeding, whatever, ADLs, whatever that is. And so the outcome measures for those types of services might look a lot different, because those are more based on the quality of the service provided, the deliverability of it. So for example, if it's transportation, was the person on time? Did they, get picked up within a reasonable, distance from where they were going? And I'm just using transportation because that's kind of a very concrete one, but versus something like an employment or like a behavior goal, where it's like, we're going to reduce the number of self-injurious incidents or reduce the number of aggressions. You can objectively measure, are we working towards that goal? Versus, we've got a Tenacare or PAC or something that is, helping the person feed themselves. The person may never be able to feed themselves due to their disability, but we can still determine quality metrics from that based on just looking at it. But I agree, there's not going to be a universal quality metric.
So I'm not going to try to get totally down the rabbit. Sorry, Kate. This is just a follow up on kind of what I was already saying. So not to just go totally rabbit hole on this, but like I bill for my agency, and there's a certain way that you bill. You go into the ICP portal, and then you like put in people's names and all this stuff and their Medicaid number, and then you get down to like what's the service you're providing and what are the number of units. It's hard for me while I'm sitting at my computer doing this to think, okay, for this particular BC visiting this person, they took this guy to Goodwill, and that part of it was they went and talked to somebody about it. And person's got a VR referral. They don't have a job coach yet, so the BC is kind of doing a little bit of exploration, which a couple years ago you all added to behavior support as an appropriate way for a BC to interact with an individual. How do I bill for that? I mean, do I look into an individual service note and say, oh, on this particular occasion, they were doing something that was relevant to employment. They did a little bit of exploration. They talked about it. Maybe they talked to an employee. I don't know how to, I mean, I agree that that's quality, but compared to being able to say, and they spent an hour and a half doing it, and so that's 6 units, and I'm not saying, we have to keep unit. I just can't, and again, it may be my deficit in
well, I think you're looking maybe for the how-to way before the process has been defined. And I think
Too soon.
I think it is hard to envision because that's kind of the struggle we have is we can't envision it.
Yeah.
At the same time, I will say, and because we haven't done it ever.
Right.
And right. And I do think here's the opportunity is, and I think employment's a really good example is whatever that quality outcome isn't necessarily, I would argue it's not about what I as the provider did every minute of the day, because every minute of the day might be I had to work, I had to help the employer understand what their responsibility was, and I had to provide support to the individual. It's a big kind of holistic that isn't just about me as the provider. That in other words, the outcome isn't just because of me and what I did. The outcome is this whole ecology or ecosystem around a person and how we set up the supports that isn't just about what we deliver to them, but about what the community also delivers. And I think that's a really important and powerful opportunity, because at the end of the day, a quality employment outcome in the community isn't, having worked as a vocational service provider, it's not because of me. It's because the individual and those around, and yes, of course, we are facilitators of that and those supports. But if the outcome is only because of me, then that's a failure, I think. And I think so. I just say, I really commend it. Is it complex? Absolutely, that's complex. And there's not going to be a metric in the very traditional. And how do I bill for that? And I do think that's an important thing, because it gets me away from being the responsible party for every outcome in this person's life and realize that my responsibility is much bigger. That's hard to do. That's going to be some big changes. I commend it. It's going to be hard. And it's going to be hard for us to struggle with because we've got a long legacy. And I mean that not as a critique.
Right.
It's not a critique.
No,
This
just
isn't,
so
so
that-
I think it's pretty good.
Yeah. Just to talk about employment. Sorry. Sorry, Katie. Do you want to go before me? Okay. Just to talk about employment, like I just recently got a job, but it's through the company I'm with, the LEL Foundation. I love it because they look towards people and other people with or without intellectual disabilities. So that's my main thing. Like most of the jobs that I applied to didn't hire me because I have a disability. And I think that's criticism. I think it's discrimination. It's not fair to us that we want to work at Kroger, Walmart, Target, wherever. They don't want to hire people with disabilities anymore. It's frustrating. So I just went with the job that I feel like that I love now. It's called Feeling Fine. It's off of Mass Ave. It's pretty close to here. But it's a cute boutique and I just love working there. And I feel like as if I had a mental breakdown here in a week or so, just for example, and I was working at a different job that they didn't understand, they would have fired me on the spot. Let's just put it that and point in perspective, because that's what people do. They don't care about our mental health.
So I think this is Kate for those of you who are online, just so we can have that for the transcript too. I really appreciate you sharing that, because I think when from the council's perspective, we hear very often that mental health and support for people with IDD who are also experiencing mental health challenges is really important. And it's not just getting mental health services like therapy, it's also having access to the words to be able to describe how you're feeling and share that experience so you can get the help that you need. That's really important. And it sounds to me like there also is a need on the employment side to do more training for hiring managers and in the community about, like you said, you love your job and you work at a boutique, and I would love to visit your boutique because that sounds amazing. But I also saw your face light up when you were talking about how much you love your job. And happiness, it's not a goal that we work into care plans, but ultimately life is about being happy. And you can't do that if the things around you are not supporting you to be happy and what you want for yourself.
Right. So when I was doing job applications with my job coach and I wouldn't receive anything back, I'm like, these jobs don't want to hire people. So and the LEO Foundation, Home Services Foundation, is the company I'm with, and Darlene, she's back there, beautiful and everything. But she put it out there that, like, hey, we have this new boutique opening. Would you like to work there? I was like, yeah. But it took quite a while for me to get the job, but I was still patient.
So I wanted to just comment on some of the value-based services. It's because it sounds like there's two conversations here. What are the value-based services that you're looking to integrate into waiver redesign or waiver reset? Sorry, wrong word. And how will you measure it? Those are the two things. And I know some of those measurement pieces come out of national core indicators. When we look at that data, I always wonder if there's a way to increase the response rate to that, the number of people that are on those waivers versus how many people actually respond to national core indicators seems relatively low. That might be one thing to consider is how do you increase that? The other thing I would look at is self-advocacy as a service, a value-added service. There's a few states that have self-advocacy integrated into their waiver system. I don't know how well that works or what that entails, but I know that it's a service provision. That might be something when we're talking about self-determination and HCBS helping people live in the community, something like self-advocacy to build those skill sets for better community living would be a value added.
Thank you. I think Katie had, no? Okay. Oh, okay. Okay.
Yeah, I
All
think
right. Yeah. All right. Thank you guys for the good conversation. So, oh, you're fine. It's good conversation. So lastly, oh, you switched.
Were you ready? I'm sorry.
That's okay. I think, yeah, just the last goal, of course, is implementing the sustainable service delivery system. And we have talked about that as well. So let's go ahead. I don't know what the music is. Sounds like the ice cream truck. If anyone remembers.
Ice cream.
I did that too. I did too.
I can't feel my ice cream. Actually, I can't feel it.
I want the Superman ice cream, please. So as we think about a sustainable framework, I want to just quickly go through those three levers we've talked about before. One is the support needs tiers. That is, again, where individuals those inter-I assessments, right? Those will inform support level tiers that are in development. Okay, those aren't done yet. We are gathering all that data from the assessments that have been completed. Somebody does have an ice cream truck somewhere in this building. And then we'll be looking at developing or are developing support level tiers. Those tiers will be individuals who have similar needs will be grouped together, right? And according to their need. And that's what we're referring to when we talk about support levels or support need tiers. That's what we're talking about. That's in development. From that, once we have those developed, there will be a model service mix. And I know we've talked about this before, or a model service or a combination of services that one would typically expect an individual with that need level to utilize. It's not telling people what services they should get and saying, here, you're in this support level, these are the services you get and this is how much. That's not the intent. It is just to give some parameters for teams so they can think about, what a service mix might look like with the individual. Then there's support budget tiers, and those budget tiers will be determined based on available resources, the Medicaid appropriation, right? And they will be connected, if you will, to these are the support need levels, these are the budget levels, and there'll be a relationship there. But they are two separate things. I do want to stress they are two separate things.
The Medicaid, does that mean like a Medicaid redetermination or what?
To the amount of funds, how we've kind of talked about the pie that we have of
Yeah.
funding. That's what I'm talking about.
Okay.
Is that overall kind of pie of funding that gets divided with support level framework more equitably across the individuals and services.
So my question is like, do they do Medicaid determinations too or no?
No, that will
would
remain
be
with
with
the
the
Division of
state.
Family Resources as it is now.
Okay, that was my question.
Yeah, no,
Thank
that's a
you.
good question. And I think the other piece is when we think about the budget tiers, we're also looking at some things other than the assessment that would include living arrangement and age, and even what are those other long-term LTSS or long-term services and supports expenses or costs for that individual. What are they receiving, not just in waiver, or what are their needs, not just from a waiver perspective, but more holistically, what are an individual's needs? And then what are those resources that are being used or needed across waiver and state plan to address those needs? And then, of course, the sustainable framework, number and type of waivers, simplification of the service array and the budget tiers, and then the slots assigned per waiver once we have the waivers designed or the number of waivers determined. Next slide, please.
Speaking of mental health,
Okay.
maybe we need to go over there.
Yeah, maybe. So I did want to just also kind of put in one list, if you will, those things that we're doing related to waiver reset. We could call them phases, but waiver reset is big, as you guys know. And everything that we're doing is working towards that final full waiver reset, right? So we've done stakeholder engagement. We will continue to do that. We have the Support Budget Community Advisory Board. I didn't name it. The SBCAB that is meeting monthly around waiver reset. We have the Intri implementation, which you can see how that utilizing those tools across all the BEADS waivers supports that future look at support levels and developing those support levels. We have the case management, the selective contracting. We know with waiver reset, however that ends up looking, right, in 2028, we need case managers in place that are well-trained and well-informed so that they can adequately support individuals and families through those changes. And then the transition planning, of course, for individuals on waivers today that will transition at the time of waiver reset. We can't start that too soon. And then, of course, we have talked, I believe last month, about our pursuit for a youth waiver. We have heard for quite some time that there is a desire for a youth waiver. Needs of children are significantly different than those of adults. So we are looking at pursuing a youth waiver, likely in advance, a little bit in advance of the full waiver reset. So I know that's a lot. If we have questions, we can certainly talk through those, but this will not be the last time you hear about waiver reset. We'll continue to have those conversations. So next slide. I won't go through this slide. You all have seen it before. It just provides a little more information on the support budgets. But just wanted to call that out. Also wanted to include the slide, yes, that talks about why we're pursuing support budgets. Again, I think, I will confess, I am steeped enough in waiver reset that I have to remind myself to talk about the why, right? Why are we doing this? Why are we pursuing waiver reset? And why are we pursuing this different model of support level needs or support needs levels and support budgets? At the end of the day, we're doing it, we're pursuing it because today there is perhaps a lack of equity in resources individuals can access through HCBS, right? It's dependent some on the waiver you're on and some other factors. And the support level framework allows us to objectively identify an individual's needs. And then the support budget allows us a way to objectively say people with this level of need should have access to this level of funds.
So on the waiver reset, are you talking about all the waivers? Are you gonna like go through all the waivers and see which waivers need more budget?
No, the full waiver reset, right, is when we will sunset the waivers we have today. And they will be replaced and we will stand up new waivers, completely new. There will be a transition period, right? So individuals in all likelihood will transition when their annual plan is due, right? But the waivers as we know them today won't be here. Now that's 2028 probably.
Okay, cool.
Yeah.
So we're still.
It's not tomorrow, so it's okay.
That's what I was wondering.
Yeah. If it was tomorrow, all hair on my head would be gray, but it's not. It's
Yeah,
2028.
me too.
Okay, so it's all right.
Yeah.
It does. It feels like it's next month, 2028. But we have some time.
In 2 years.
Holly,
Yes.
has it completely because I know at one point we were talking like late 2027. Has it completely changed to the transition period being 2028? And the reason I ask this is I believe my annual meeting is typically in December. So would I start transitioning in December of 2027 or would I have to wait till December of 2028?
So I can't give you a firm answer on that right now, Lexi. We are full steam ahead. I want to be clear about that, but we also want to be very thoughtful. And I do feel like previously we had talked about 2027. I do feel like we are sliding into early 2028. But we will keep you all apprised of kind of where we are on that timeline. But again, we're full speed ahead, but we want to make sure that we want to be very thoughtful and intentional in the process. So
understandable.
Yeah. But we'll keep you all, we'll be talking about this a lot. You're going to have to hear from me a lot more. I'm sorry.
No problem. I like hearing about this stuff, so it's cool.
Okay.
Thank you.
Holly?
So then,
Sorry. I was going to say, with the youth waiver being a possibility, will there be any kind of, I guess, movement forward to coordinating how that might work with the schools or with the IDOE as well?
Yeah, that's a great question. Yes, I think as we get further in with the youth waiver, I do think it's important that we engage with Department of Education. I will say, and I know you know this, a family's experience with the educational system often is related almost solely to their local school district. But yes, I think that's an important call out and we do need to account for, again, those entitlement services for youth and how do we support them in accessing those in an appropriate way. Yeah, good call out.
with the youth waiver, possible transition before, like, is there an idea of how much sooner that transition would start than the full waiver reset?
Not right now. I think we would like to, I think if we need to get it, we would need to work through the youth waiver and get it implemented in 2027, probably early to mid 2027, if we're going to do it before waiver reset. And that is next week, by the way. Not really, but yeah, that's kind of in discussion, or that is in discussion right now as well as watching that timeline.
Holly, is the envision that if youth only on that waiver and not on the other waivers? So if
Yes.
they're youth, they're on that waiver, only that waiver?
Yeah.
Okay.
Yep. Let's see. Oh, and another thing on here that I just want to note is the supports budget does promote some transparency there so that individuals will know walking into their annual meeting, so to speak, what resources they have available through not through state plan, through the waiver, in terms of, in consideration of also what other services they may be accessing through state plan and other resources. And again, it allows us to predict, I've been talking for way too long today, spending, both for people on the wait list as well as individuals and services. So yeah, we can go ahead and go to the next one.
Holly, I have one more question. The requirement from last legislative session to create an assisted living waiver, how does that interplay with the waiver reset?
I'm so sorry.
I didn't see living.
The assisted living waiver is for 60 plus.
Okay, so there's no implications just on that. Okay.
Good question, though.
That would fall under your policy.
OMPP.
Yeah. Yep. I won't go through this again. I wanted to include it though, if we can go to the next slide. I've updated this next slide and graphic. Please note that those participant counts are current as of April, as of April.
Say current, people say
Yeah,
current.
I know.
Put that on
The
the
devil's
table.
in the
I'll need to put that on
details,
the
as Jim said. Yes. Okay, I can add that.
Just because people will say.
Yes. So I've added in the youth waiver there that you can see. That is a difference from the last time you saw this slide as well. We have the case management and the youth waiver, and then that green is more representative of the new waiver structure that we would be in at the time of waiver reset. Let's go ahead and
Can you maybe just go back?
yes, please go back.
I just want to highlight on that because I think you did this intentionally.
Oh, I did. Thank you.
Holly appears to have bolded the kid numbers. And I just wanted to call out the numbers of kids that we are serving is now outnumbering the adults.
Yeah. Thank you, Kathy.
Yep,
I missed that.
I mean, by
Yeah, so lots of views.
So the bold ones mean kids.
Yeah, the bold ones
So
are
like the 10,000.
Now there are some that are
The 13.
So
Yeah.
basically 10,000 FS is 0 to 17. I mean, over 10, and then 18 to 26 is 7,000, 27 to 56. And then H and W 2,000, 0 to 17, 798, 18 to 26. Okay.
Yes, and our ages on the family support waiver wait list very much correlate with this as well, in terms of the age of individuals on the FS wait list. So,
Jory, just quickly, I saw your face. So it's interesting because I think you probably didn't realize. It's interesting. I just was, because I think we are noticing people don't necessarily I mean, we say it sometimes, but I don't think not to call you out. I just saw your face, was like, oh.
In my professional, so I'm assistant special ed director in the district, and I think that's very reflective though of the needs that we're seeing in schools. The school needs are significant, and I oversee the developmental preschool program as well as then like more of our classrooms for students who have more intense needs, and just the level of the growth in those needs is startling. And then how are we providing? It's a very passionate topic because the classrooms, we are adding a 4th classroom. Our developmental preschool classrooms are exploding, and we're a smaller district. Some of the larger districts, and we have students, I mean, we've tried to figure out how do we catch these kids as 2 or 3 or 4-year-olds who already have the identified disability versus like a developmental delay. How do we catch them, get them on the waiting list for the waiver? So we've just added little bits to like our case conference template, so things to ask, but the number of students that are not on the wait list yet, that haven't even signed up. And then that's the number of kids that are on it. And just knowing in my head, like the conferences I've sat in with 11-year-olds or 15-year-olds that have not been caught. And it's just, I just think it's very reflective. Kind of.
I think what they should do is like have someone test them and then figure it out. Cause that's what my mom had me do, was be tested every year to see where I struggle at. And then they could help them get on there.
And these are students we've already evaluated.
Even if they weren't evaluated, they should still test them,
And I think to your point, Jory, I think that's where the youth waiver comes in, because the services and supports that are offered, right? I mean, aren't, I think about this as my first day on the job years ago, is what are you waiting for? Because the problem is I think people are waiting, but it's what services are on that array, right, for a child. And there's other services that the school system provides, right, that is not a waiver service. And so I think that's, the movement is because what are you wait? I mean, because a lot of times it's not the services that are there, other DOEs, you know what I mean? There's other services and supports that are already in place that are helping that. So it's kind of.
Can I throw something out there about the numbers? This is Lexi. So I think, so I found out I got on the A&D waiver originally. I've been on the waiver for almost 10 years, and about half of that was A&D, which is now health and wellness. And I found out from my doctor, believe it or not, which I heard is rare to find out about the waiver from your doctor. I think we're seeing more kids on the waiver, more youth on the waiver or on the waiting list now than historically, is because and I see this a lot on social media, especially Facebook and stuff, there's a lot of peer-to-peer support for families. Like parents are supporting parents and caregivers are supporting caregivers. There are, Facebook groups for stuff like that. And I think more parents are hearing about the waiver, honestly, through other parents through social media than historically, that wasn't a thing. That wasn't even as much of a thing when I got on the waiver 10 years ago. But I think historically, for people my age, schools weren't talking about it, doctors weren't talking about it, and now parents are seeing other parents with their kids on it on social media and finding out from parents. And there's just so much peer-to-peer support, especially with social media.
yeah, good point, Lexi.
Thank you.
Thank you. Kathy, thanks for bringing us back to that, to point that out. No, I appreciate it. I'm glad you did. Just want to note, we've already talked about most of this, but do want to just reiterate that we are analyzing that data from the Enterprise Now. And then if we can move to the next slide, I want to provide an update on some of the activities that we're in process of or have completed already with regards to waiver reset. HSRI, Human Services Research Institute, is a contracted entity with BEADS. They now have 2 years of Medicaid claims data. That includes the waiver, the HCBS data, as well as state plan data. So we're looking at, again, at that holistic approach, right? And they are cleaning that, right, from a data perspective, and then working on that analysis. We have also, and this is not we BEADS, this is one of our internal partners in FSSA, our friends over at Office of Medicaid Policy and Planning, have launched an internal work group exploring state plan home health services, and we are a part of that. We've held some initial meetings on the plans and goals for waiver reset with our cross-system partners. That includes our friends at DMHA, of course, our family now in the Bureau of Better Aging, as well as OMPP. We have also completed an in-depth review of our current service definitions across all 4 of the BEADS waivers. I think we've talked about before, we have a lot of services that we offer, and how can we simplify that, right? How can we kind of consolidate services or combine services, or in some way make that system, that service array a little easier to understand, while also keeping that eye on quality services. So we have completed that. We have completed round 1 of research into some promising practices in other states on all things waiver reset, right? All different topics there. And then we began some additional research into promising practices earlier this month. We have a preliminary service array recommendation from HSRI, or no, I'm sorry, we don't have it yet, but it's in process of being developed for us to review. And then, yes, oh, I'm sorry.
You're fine, you're fine. On that preliminary service array recommendations, is that going to be discussed with the SB cab?
Probably so. I'm not sure the timeline for it yet, but I would think we will talk about that with the SB cab group.
Thank you.
Thank you. Good question. We have also provided waitlist data to HSRI because as we talk about the launch of a youth waiver and waiver reset, we know we've got multiple waiting lists now for HCBS. So we need to be looking at that and deciding how that's going to work moving forward. And then,
sorry, Holly.
Oh, yeah, sure.
Well, Kate left, so somebody asked that question. But you know, she passed it on to me. That waitlist data, is that kind of demographic data, age? Yes. Okay, so it's not level of care, it's
No,
nothing
no,
like that.
no.
Okay.
Well, let me rephrase that. That waiting list data would include what level of care was met by the person, right? Because we have the nursing facility level of care and the ICFID level of care. So does that make sense?
Yes, it does.
That's what
You're not
but
looking at NRI data, essentially.
Right.
Got it.
We're looking at the level of care data.
Got it. Thank you.
Yeah. All right. Good questions. And then again, need to update this because the final awards for the new case management contracts have been made. So, and we've talked quite a bit about case management, and also the data analysis for the budget framework development has begun. So while we're working on identifying the support levels for individuals and what that will look like, or the support level framework, we're also analyzing that data, or HSRI is analyzing the data regarding the budget framework, which again considers HCBS and state plan. So it's all of the long-term services and supports data. Okay, going to shift just a little here. Little shift. Any questions on waiver reset before I jump in here? Okay. Okay. So the home and community support professionals statistics. So we have a reporting period. This is the training registry, the HCSP training registry that we've launched. The total number of learning path certificates granted since July is over almost 37,000, which is really good. Total time spent learning is about 188,000 hours. Wednesday appears to be the day that most people do their training, huh? Yeah, that is interesting. It's middle of the week. And then the user device description just talks about what device people are using, right, for the training. So again, we've had really positive feedback on the HCSP training.
Is this professional stats like the tests that people have to take to be a caregiver or anything?
So the HCSP training, right, includes that competency testing.
Okay,
So
okay.
to get the certificate, you correct me if I'm misspeak.
But when you say caregiver, I don't know, Tilly, what you're,
Like,
you know what I mean? Like
support staff.
Yes, like
Staff that-
yes. I just want to make
Yeah.
sure because it's not all service like, but yes,
So
traditional.
is CIH on it?
Yes.
Or, okay.
Yes, but like
That's
a
what
music
I-
therapist, which I know you
No.
wouldn't call it, is not considered a home. But yeah, but traditionally the ones
Okay.
what you're thinking of is
Yes, CIH.
yeah,
Yeah.
yeah.
Or day programs? Do day
Yes.
programs?
Yes.
Okay, cool. Thanks.
Okay, we've had really positive feedback. We've been very pleased with how well it's been received.
Yeah, and we're going to provide the recertification is coming up in terms of folks, and then also the med admin we're still working on. It's taking a little bit longer. The providers are obviously able to still use their own, right? They're not being penalized for anything. So yeah, so it's going pretty well. We're going to share much more information, and we're also coming up on a year, so we're going to be able. It's hard because we didn't have data on direct support professionals prior to this. So we don't have anything to compare it to much. I mean, we have some obviously national, surveys that are done, but but now that we're almost at a year, we can really look at, some things. And I think it's going to be interesting as we're moving forward. So we will be presenting at the quarterly MFR, which is what? When is that? August? I don't remember when the next one is. Sorry, I'm blanking, but we will be providing details on this, just some more data and everything. So it's exciting.
We all have brain farts sometimes.
I know. I can't remember. It's May. Yeah.
Yeah.
Okay. We have about 20 minutes. Obviously not going to hold you here and to stare at each other, but if we, but oh yeah. I know.
Good job.
Oh, wait, we've got 20 minutes worth of questions. Go.
So
We need Kate back.
I'm just gonna add, since we do have some time, and we obviously I mentioned earlier around sort of the questions related to the value-based payment or purchasing, our interest in the employment space, competitive integrated employment space. And that's an area that we've continued to work toward making incremental progress. But as of, I think, this week, and you two correct me if if I can't read clearly, apparently, we have less than 500 sub-minimum wage workers in the state of Indiana right now. And that is a significant decrease from where we started. I don't know, feels like yesterday, but it was a couple of years ago. And so for us, that continued. When I said that earlier, it's because we have a desire here to make some meaningful progress in Indiana, and I think we are very much on the right track. We do still have a number of 14C entities, but a number of those are working at transitioning out or phasing out their 14Cs, even so later this year. So I want to just acknowledge the work that everyone has done in that front, but that don't feel like that's an opportunity to let up on the gas at this point, which is why we're talking about value-based payment as a mechanism to help forward the employment outcomes for people even further. So I wanted to take a minute to share some of that data. Didn't totally fit into the agenda today, and I certainly will have some more information to share with you at future advisory meetings. But I because you all have been so invested and involved in these conversations and some of the work that we've laid forth in our plan, I wanted to take an opportunity to put that in front of folks and share that update.
Yep. So in that 500, is it with people with intellectual disabilities, or that because they can't have a job, or the person wants a job, but the jobs like Target, Walmart, Kroger, Goodwill. I know Goodwill hires people, but I don't preferably like working there. But is that because the 500 is because jobs now these days are not accepting people with intellectual disabilities?
You feel free to jump in. There's actually, it's a number of reasons why they haven't, and some of it is at this point either they haven't had those conversations and been planning around competitive integrated employment. They're just at different places and spaces depending on their own kind of trajectory, kind of how long have they been in a sub minimum wage scenario, and obviously, sometimes it's harder for folks to transition away from that. There's a lot of forces at play for some of those people for maybe why that's the case. But knowing that number, I think, is a much more a number that's much better, I guess, from tackling those very individualized issues on an individual basis to be able to help them work through that or look at a trajectory of where they're headed and how to get there. Holly or Jess, anything else you would add?
Yeah, I know. I think that was a great response. I would also add that I think some of the individuals that are maybe still in those settings too may just have lots of questions about competitive integrated employment. And I think I'll be selfish here and make a little plug for a couple of the newer services, the career exploration and planning, and also that those benefit discussions, because I think those are opportunities to for our system to engage with those individuals and their families about what are the other possibilities,
Right. I think my mom's supposed to do my benefits review with someone, but they haven't reached back out. So then my VR counselor and I met yesterday with my mom and Darlene, and she said, we're thinking about taking you to the next step and closing your case, because they couldn't really work with me because my case manager is in Johnson County and I work in Marion. But I like the job where I'm at because it's just easier. They love people with intellectual disabilities and they want us to succeed and move on from what's going on right now. Like, I get it. It's hard to if I was looking for a job, like, let's say 5 years ago, which I did have a job, but then it's harder these days to get a job because of all the changes in the state and with the government. And sorry, I have to say his name, even though I don't like him, Trump's stuff. But I don't understand why he's doing this to people with intellectual disabilities. But my point is, like, he doesn't know how well we succeed. He doesn't know anything. And he has someone with a disability, and he probably disowned them, like, crazily, but I don't like him, so.
Well, again, I think as you mentioned, though, you know your possibilities, right? And I think we likely have some individuals maybe who don't, and we need to be having those conversations.
They need more support in it.
Yeah. I'd also like to make a statement, and the two other lawyers in my room, people cannot not hire you because you have a disability. So just, we'll have a side conversation.
Yeah,
but
yeah.
that is not okay. So just making that public statement, someone cannot hire you. That's discrimination. So anyway, okay. So I think, did you have a question, Lexi? And then I know Katie has a question as well.
Yeah, I had a question. Actually, I have a couple. So, I was asked by an individual 2 questions. So the first was, how do you plan on targeting the wait list for FSW, CIH, health and wellness, and TBI? And my second question is, it's kind of a 2-parter. Like when slots open up on July 1st, how do you plan to target the FSW waitlist, and kind of what's the plan for addressing CIH?
Yeah, and Lexi, I'm sorry, I didn't get a response out to you until this morning. That I'll follow up with you on that. I think those
Okay.
are, yeah, that's a longer conversation than today, and but I can follow up with you for sure. Those are good questions.
Okay, thank you. Sorry, I haven't been on my email, so I haven't seen
No,
it.
believe me, I understand. I will never criticize someone for not reading their email immediately. Okay, you're good.
Okay, thank you.
Katie, you had a question, I think.
Emily, is there a timeline on the updated living caregiver bulletin?
The amended one?
Yeah.
Yes. I don't have a date that we will be able to issue that, but we are working to get that out as soon as we can. I'll let you know as soon as we have that. Thank you.
I was just going to ask if in the future at a meeting, maybe we could have conversation about choice and how that is serving families under 60 and how that intersects with then the BEADS HCBS and how someone might find themselves on one path or the other. That just, since we have someone here now that can speak to that, I would love to learn more about.
And we can watch that DDA video again, right?
Yes.
I have one kind of follow-up comment from our last meeting, which I believe was our March meeting. At that time, Holly, you had expressed the opportunity for NABC members to provide you and BEADS with claims issues from December, and these were issues that happened because nobody did anything like intentionally wrong, but there were some auto-generated budgets in January that then ended up where there was some shortfall in December, and we were having difficulty finding traction to get those legitimate claims paid. And NABC, all the members, we really appreciate the way that BEADS partnered with us to look at over 500 claims. And I mean, it took a minute. I don't think that you were expecting it to be quite that big a number. But you know, a lot of members of NABC have expressed to me gratitude for your willingness to do that. And I think that it's important. I mean, you brought it up 2 months ago that you were willing to do this and you followed through, and we really do appreciate it.
No problem at all. We're all in this together. So work through things together.
Thank you. Great. Okay. Next meeting, July 15th, here at the Government Center in Room B, and BRS, Teresa Colazar will be giving an update from BRS. All right. Thank you, everyone. Thanks, everyone online.
Thanks, everyone.